Okay, it's 12:45. So good afternoon and welcome back to this PTAC meeting. I want to extend a special welcome to anyone who has just joined for the afternoon. I'm Grace Terrell. I'm the Vice Chair of PTAC. I will be handling some of Jeff's facilitation duties this afternoon because he's on the PRT for the proposal that we're going to discuss this afternoon. But before we do that, at this time, we're honored to be joined by a member of the HHS leadership. I'm excited to introduce Brad Smith, who's the Senior Advisor to Secretary Azar for Value-Based Transformation, a Deputy Administrator for the Centers of Medicare and Medicaid Services, and the Director for the CMS Innovation Center. Mr. Smith joined HHS in January 2020 after serving as the Chief Operating Officer of Anthem's Diversified Business Group. He brings with him extensive experience innovating in the care delivery and value-based care spaces. Mr. Smith co-founded and served as the CEO of Aspire Health, a healthcare company focused on providing home-based palliative care services to patients facing serious illnesses. And with that, it's my pleasure to welcome Mr. Smith.
Thank you guys for having me. I deeply understand how important the work of PTAC is. And just to give you guys a little bit of background, prior to coming into the administration, I was running a healthcare company that did palliative care. And we were part of a coalition of folks who brought a model through CTAC to PTAC. And through that process, you guys gave us really helpful feedback. We refined our model a lot. And as many of you may remember, you also approved another palliative care model around the same time. And then CMMI, before I was ever there, took those two models that came up from PTAC, other ideas they were hearing, and put together the SIP model, the serious illness population model that they've recently announced. So I've had the opportunity to firsthand see the importance of PTAC, see the way that it can make participants and folks who are bringing models to improve their models, and then seeing how CMMI can use that information to roll out a model for the whole country. And so I just want to start by saying I deeply understand how important your work is, how important it can be for providers across the country, and how important it can be for CMMI and CMS in informing everything that we're doing. I'll start just by talking about sort of my time so far. So as you guys know, I joined in January, and I spent the first 2 months going through all of the models that we have done. It's about over 45 models now, and trying to understand the impact that they had and lessons that we had learned. Over the past few months, have obviously been pulled into the COVID work, almost working full time on it in March and April. But now I'm probably about 70–80% back to my CMMI job, and excited to dig back in with the folks from PTAC, with the CMMI team. As we think about the rest of this year and going forward, maybe I'll highlight a couple of areas that we're thinking about and some of the things that may be helpful for your all's conversation. So one piece is that as we went back and reviewed all the models, I think we had a bunch of really important lessons learned. So we've learned a lot about how to think about benchmarking, the importance of, for example, back testing benchmarks on data to make sure that they're fair and accurate both to participants and to the government. We've learned a lot about operations, how to make sure that we're implementing our attribution really well, how to make sure that we're being thoughtful about the investments we're making, how to measure quality metrics. And I think one of the things that you're going to see us focused on the rest of this year is really operationally making sure that we're supporting participants well, that we're making sure all the existing models that we have are successful. And by successful, I really mean driving one of two outcomes, either one, helping lower cost, or two, helping improve quality. The other piece is we, of course, are going to be thinking about the things that have happened as part of COVID and some of the flexibilities that we've gotten generated. I know Administrator Verma probably talked about this earlier today. The way from the CMI perspective that we're thinking about those COVID flexibilities is that we'll start by CMS reviewing them and deciding which of those flexibilities make sense to continue as part of the core Medicare program. And then of the other flexibilities that they're not planning to continue, we will then evaluate those for potential incorporation into our CMI models. And especially in models where participants are taking capitated risk or two-sided risk, those are models we're going to look to give participants as much flexibility as possible. Just talking a little bit more about PTAC, and I think the ways that we can work together. Number one is the kind of feedback that you all have provided on models to providers and participants has been extraordinarily helpful. And I think you all continuing to do that, us sharing lessons that we're learning around benchmarking, some of the challenges of adverse selection, et cetera, I think will be really helpful, and potentially maybe we can come back and even share some of those lessons learned with you all at some point. I think a second piece will be helping us think about new areas that we should consider launching models. As an example, to date, we haven't done anything in the behavioral health space. We've done a few things, but want to do more in the social determinants of health space. We've done a lot around post-acute bundles, but want to do even more there. And I think being able to hear from you all and hear from providers across the country ideas they have, models they've tested, that will be extraordinarily helpful. And what we are committed to is anyone that you all recommend, we want to meet with them. We want to understand their recommendation. Where appropriate, we want to incorporate that with everything else we're hearing from across the country to roll out models. So overall, I just want to thank you all for being great partners. We are here to work with you. We are highly committed to value-based care, hopefully, as you saw in the model flexibilities that we had, and look forward to building a great partnership with you all. With that, I don't know if anyone has any quick questions, but just appreciate being able to be here.
Thank you, Mr. Smith. Any questions?
Thanks, Brad. Look forward to working with you. It's Jeff.
Thanks, Jeff.
All right. Well, thank you for providing those remarks, and hearing nothing from anybody else. I hope you'll continue to listen in this afternoon. But let's proceed with the proposal that we're scheduled for this afternoon. So to remind the audience, I'm just going to reiterate the order of activities for our review of a proposal. First, the PTAC members will make disclosures of any potential conflicts of interest, and then we will announce any committee members not voting. Second, we will have a discussion of the proposal that will begin with a presentation from the preliminary review team, or PRT, charged with conducting the preliminary review. After the PRT's presentation and any initial questions from the PTAC members back to the PRT, the committee looks forward to hearing comments from the proposal submitters and the public, and then we'll deliberate on the proposal. And then we'll vote. I'm not going to go into the details with how we do that with respect to that as we reviewed that this morning, and I want to make sure that we've got time for our deliberations this afternoon. So with that, let's just go ahead and proceed forward with the proposal that we have at hand this morning.
Grace,
this afternoon, which is
Grace,
yep.
I didn't mean to interrupt, but I just wanted to make sure. I think I saw Jennifer had a question, and just circling back, Jen, the time may have passed, but just wanted to make sure you had an opportunity.
You had it with so for whatever reason, it's been slow to show you when you have questions on our things. I think that happened to you this morning. Was that for Brad Smith? Okay. All right. I apologize. Is he still available where we could get him back on? If not, my apologies. Okay. All right. Well, Jeff, just stop me quicker next time, okay?
Okay. Sorry, Grace.
Okay. So the proposal that we're now getting ready to discuss is the patient-centered asthma care payment. It was submitted by the American College of Allergy, Asthma and Immunology, or ACAAI. So let's now go through and read or declare any conflicts of interest or disclosure statements. And just as Jeff did this morning, I'm just going to go, since it's virtual, I'm going to go through and prompt you one at a time. So Grace Terrell, CEO of Aventis Whole Health, and I have nothing to disclose. Next is Jeff.
Jeff Baylett, CEO of Alteus, nothing to disclose.
Paul?
Paul Casal, New York Presbyterian, nothing to disclose.
Charles?
Charles DeShays, the CMO of Highmark Inc., nothing to disclose.
Kavita?
Hi, Kavita Patel, Brookings Institution, nothing to disclose.
Angelo.
Angelo Sinopoli, Chief Clinical Officer of Prisma Health, nothing to disclose.
Bruce.
I'm a health economist in Washington, D.C., and I have nothing to disclose.
Jennifer.
Jennifer Weiler, Chief Quality Officer, UC Health, Denver, and Professor at the University of Colorado School of Medicine.
Nothing to disclose?
Nothing to disclose.
Okay. All right. Thank you all. And I'm going to now turn the microphone to the lead of the preliminary review team for this proposal, Angelo Sinopoli, to present the PRT's findings to the rest of us on the full PTAC.
First, welcome to the afternoon session, and big thanks to my fellow PRT committee members, Jeff Baylett and Bruce Steinwall. If we could flip to the next slide. And we're going to review the PRT composition and roles, then the proposal overview, and then the summary of the PRT review, identify and discuss some key issues, and then we'll go through each of the 10 criteria. Next slide. So in terms of the team composition and role, we did review some of this morning. So the PTAC chair and vice chair assigns 2 to 3 PTAC members, including at least one physician to each complete proposal to serve as the PRT. One PRT member is tapped to serve as the lead reviewer. The PRT identifies additional information needed from the submitter and determines what extent, if any, additional resources and or analysis are needed for the review. Assistant Secretary for Planning and Evaluation, ASPE staff, and contractors support the PRT in obtaining these additional materials. The PRT determines at its discretion whether to provide initial feedback on a proposal. After reviewing the proposal, additional materials gathered and public comments received, the PRT prepares a report of its finding to the full PTAC. The report is posted to the PTAC website at least 3 weeks prior to the public deliberation by the full committee. Important to note that the PRT report is not binding on the PTAC. The PTAC may reach very different conclusions from those contained in the PRT report. Next slide. We'll briefly review the proposal. So background, asthma across the United States affects about 26.5 million people, including about 3.5 million Medicare beneficiaries. The submitter estimates that Medicare spends about $454 million on asthma-related emergency room visits and about $1.1 billion on asthma-related hospitalizations. When correctly diagnosed and managed, asthma does not have to be a life-threatening and costly disease. The goal of this proposal intends to give physicians specializing in asthma care, primarily allergists and immunologists, the resources and flexibility they need to better diagnose and manage patients with asthma. The proposal seeks to save costs and improve quality by avoiding unnecessary hospitalizations and ED visits through better diagnosis and management of patients with asthma. Alternative payment model entity, as they describe, an asthma care team consisting of an asthma specialist, such as an allergist or an immunologist, a primary care provider, as well as other providers as needed. Next slide. The core elements of the program are dividing asthma care into 3 categories for varying levels of care. These are needed for treatment stage, disease severity, and therapy. Number 1 is diagnosis and initial treatment for patients with poorly controlled asthma. The next phase would be continued care for patients with difficult to control asthma. And the third would be continued care for patients with well-controlled asthma. Beneficiary eligibility and payment around, amounts for participating acts differ in each category. The PCACP excludes asthma patients with certain comorbidities such as COPD and lung cancer. And additionally, participating asthma patients are excluded from all performance assessment measures if they fail to stop smoking, obtain certain prescriptions, or fail to obtain prescription medications, or attend scheduled appointments. Performance on service, utilization, spending, and quality is assessed relative to other participating ACTs, with adjustments to the PCAP payments based on performance. ACTs must meet minimum quality standards to receive the bundled payments in categories 1 and 2. The next slide. We'll go into a little bit more detail about the various categories. So category 1 is defined as the diagnosis and initial treatment for patients with poorly controlled asthma. Eligibility for this criteria is a new patient with asthma symptoms without a diagnosis in the last year, or those with poorly controlled asthma, are on treatments that are not consistent with current guidelines, and are enrolled by the physicians at the initial visit. Payment. Bundled monthly payments for up to 3 consecutive months, replacing some fee-for-service billing for evaluation and monitoring E&M codes for asthma-related clinical services and selected tests. Payments are stratified in this particular category in up to 5 levels based on patient risk. Initial adjustments and payment would be up or down 5%, payment based on performance increasing to up or down 9% over time. Performance measures would include care quality, percent of patients with improved asthma symptoms, improved spirometry measures, reduced ED or urgent care visits, and ratings on practice access. Service use and spending, the average number of months to diagnosis of asthma, the price standardized average total per patient spending on allergy testing, asthma medications, urgent and ED visits for asthma symptoms, and asthma-related hospitalization. Next slide. So the next category was care for those, continued care for patients with continued difficult to control asthma. The eligibility here are beneficiaries who do not have well-controlled asthma after medication trials, or those taking certain potentially high-risk medications, or with recent severe symptoms or hospitalizations or significant comorbidity. The payment, again, is a bundled monthly payment, replacing some fee-for-service billing in the E&M codes for asthma-related services and selected tests. The payment in this category is stratified into 4 levels based on patient risk. Initial adjustment, again, is similar to the previous phase of up or down 5%, or increasing to up or down 9% over time. The performance measures here are care quality as it relates to improved asthma control, decreased control, and rating of practice access. The service utilization and spending performance measures are assessed using the price standardized measures as outlined previously in category 1. Next slide. So in category 3, is defined as continued care for patients with well-controlled asthma. And eligibility here are patients with well-controlled asthma who were previously enrolled in categories 1 or 2. From a payment perspective, monthly supplemental payment that covers non-face-to-face visits and communication between physicians. The performance measures here around quality consist of percent of patients with decreased or worsening asthma control, percent of patients rating access to physician practice as very good or excellent. Service utilization and spending measures use price standardized average total per patient spending on allergy testing, asthma medications, urgent and ED visits for asthma symptoms, and asthma-related hospitalizations as described in categories 1 and 2. So that is a very high-level review of the proposal. And as we walk into the summary of our PRT review, I would like to start out by saying that there was a great appreciation of this submitter trying to move us forward with a first specialty-oriented APM. And there's clearly a lot of attention to detail in this submission, particularly related to sticking to well-known asthma guidelines from a clinical stratification model was very detailed. The PRT committee did find some key issues that influenced our thoughts as we reviewed the criteria. So if we'll move on to the next slide, we'll be starting to go through some of those. So just at a high level, some of the key issues that we identified was that the proposed model lacks sufficient scope for implementation as a standalone APM. And we'll talk about that in a little more detail as we move forward. With 3 separate phases, diagnosis, difficult to follow, and controlled follow-up, each having monthly evaluations, and within each having 4 to 5 different payment levels in each phase determined by the patient's clinical stratification, we thought that this was a highly complex model. The program includes the potential to maximize bundled payments through patient selection, because the patients are selected at the end of the month after, or at least assigned to a payment model after the month of care. The proposal also falls short in its approach to care coordination in regards to its lack of focus on social determinants, transportation, co-payments, et cetera, in a Medicare population who is known to have more comorbidities and debility and needs more support than most other younger patients might need. Next slide. The proposal does not clearly identify how the Medicare fee-for-service payment system as it exists today causes failures in an ability for a doctor to make an accurate diagnosis, and throughout the document refers frequently to a focus on the need for increased fee schedule rates. And next, the proposal may overstate the possibility of savings, citing a 50% reduction in ED visits and hospitalizations in this Medicare population. Inclusion of some tests, but not all tests, increases complexity and can further reduce potential savings. Allocation of the payment from the specialist to the primary care physician in the second phase was left unspecified and not clear as to what specific changes and activities this would attempt to improve. So with that, we'll go into the individual criteria. So if we go to the next slide. So scope, the PRT committee felt that from a scope perspective, this did not meet criterion, and the decision there was unanimous. We did agree that no APMs in CMS today specifically address asthma, and it is a chronic condition with a high prevalence in the general population. However, looking at various data sources, as you look at patients above 65, the CDC, for example, estimates that from an ER visit standpoint, that there may only be 126,000 visits a year with about 24,000 admissions, and that the cost of those was somewhat less than was suggested in the proposal. Also, with the exclusion of certain cohorts from this asthma population, like those that also have concomitant COPD, would significantly decrease the number of patients eligible for this model. And in some of the data discussed, above 60% of all asthma patients above 65 who do seek hospital care have concomitant COPD. Also, taking into consideration this age population who may already be enrolled in Medicare Advantage or other models, which may also exclude them from this model, continues to push the number of eligible patients even lower. And patients with asthma and could also participate in other APMs like ACOs or CPC Plus, where those models were available. Next slide. So from a quality and cost standpoint, again, the proposal recognizes the need to facilitate physician engagement and emphasizes shared decision-making between patients and providers. However, the potential Medicare savings we felt could be significantly overstated by assuming that effects on improved asthma care in this particular population would be comparable to that in the younger population. Most of the data was around younger populations, and there were no specific data related to the Medicare population. Furthermore, using the submitters' numbers of about $1.5 billion of total spend from ER and hospitalization, even if they were able to decrease those costs by 50%, that would result in $750 million in savings, all comers, before you remove the patients with COPD. And if only achieved a 25% improvement, would bring that down to $375 million. Given previous discussions we've had with Andy Bowler and CMI of our goal of trying to obtain a scale of $10 billion, that was a significantly lower number than we thought would hit that goal. And again, the model does not contain provisions to address social determinants of health, as mentioned before. And the model also, again, did not delineate how the care between the primary care and the specialist would look and what that specifically was trying to incentivize. Next slide. Criterion 3. The proposed model is, in our opinion, highly complex, with multiple tracks assigned by provider assessment within the three main categories, and this is done on a monthly basis. We felt like this complexity could make it difficult for providers to participate and particularly for payers to administer. The proposed payment models are based on a monthly risk model, yet the participating provider has discretion to determine which patients are included at the end of each month. No attribution or assignment has occurred. Recent improvements in the Medicare physician fee schedule are intended to support these types of care in the PCAP proposal. The proposal does not identify, and we felt like this was a significant question, is the proposal does not identify how the present Medicare fee-for-service payment system causes failure in a physician to accurately diagnose asthma or prevents him from ordering the test or prescribing the medications that a patient needs to successfully manage their asthma. Next slide. The value over volume. PRT unanimously thought that this does not also meet criteria. The proposed model, proposed model provides a payment amount to enable providers to tailor services to patient needs, certainly, The monthly framework and the ability to potentially enroll patients who will be financially beneficial to the provider reduces accountability for the provider. The mechanics of the proposal seem insufficient to consistently drive more value than is what's currently available in the standard fee-for-service model. The proposed model does not clearly address major known drivers of improved health among Medicare patients, again, such as social determinants of health. Next slide. Flexibility, we did feel like it met the criteria for flexibility. The proposed payment model would give participating providers and patients flexibility to provide a broader range of services that could be beneficial in diagnosis and controlling asthma, although once the patient commits, the patient is limited to receiving all of their care from that particular specialist during that time period. However, it's still unclear how the patient's primary care provider and asthma care specialist would work together to improve the flexibility and benefit the patient. Next slide. Ability to be evaluated. PRT committee did not feel like this made met the criteria. The proposed model recognizes the importance of evaluation and notes that the types of data that would be available for model participants, including claims, patient-reported outcomes, and EMR data. However, the complexity of the proposed model with up to 5 payment levels within each phase and potentially 1-month intervals during each, along the entire course of the patient's care, could make it difficult to evaluate. It will be hard to determine whether or not the proposed model saves money, given the proposal does not have a present benchmark. Proposed evaluation comparison is to performance by other ACTs, which don't exist today, but even if they did, controlling or comparing ACTs to another ACT rather than to standard asthma care, we thought was somewhat problematic. Next slide. Integration and care coordination, we felt like this does not meet criterion. The model emphasizes co-management between primary care, yet does not specify how care would be coordinated between primary care physicians and asthma specialists beyond what happens or should be happening today and how this is incentivized. The model does not elaborate on care management outside the office other than an occasional contact by a respiratory therapist. Some practices such as phone calls to coordinate with other providers we felt were expected under current standards of care. The proposal also does not address how care coordination might evolve over the course of the model, such as when a patient moves from a difficult to control phase to a well-controlled phase. Without clear guidelines, the negotiations between the PCACP, payments between providers in each circumstance could be burdensome for providers in practice and may hinder the coordination. The model does not identify specific innovations in care delivery or approaches to improve care for patients with asthma that will be included beyond tools already available in a fee-for-service model. Next slide. We did believe that patient choice, that criterion was met. The proposal notes that this enhances patient choice by providing an additional option and desirable services for patients. On the other hand, patients would be required to commit to receiving all asthma services from this team during the month covered by the payment, which could limit patient choice from that aspect. Next slide. From a patient safety standpoint, we did believe that it met criteria. The submitters expect that this model would promote early and accurate diagnosis, encourage timely development of care plans, educate patients, and facilitate identification of asthma exacerbations early. The proposal also notes that the proposed minimum quality standards would protect patients from undertreatment. The emphasis conversations and shared decision-making is a strong element of the proposal. Next slide. From a health IT standpoint, we felt it met criteria. The proposal indicates that regular electronic communications between specialists and primary care would be required, and the payments in the proposed model could be used to support outreach and remote monitoring through technology to help manage asthma and patient compliance. So again, I would say in summary that our biggest concerns were the scope, the complexity of this payment model, and concerns around how the present fee-for-service model prohibits accurate diagnosis and management of asthma patients today. That's my presentation.
Thank you, Angelo. Any comments from either of the other two members of the team before we ask any of the rest of us if we've got questions for you?
This is Bruce. I was going to emphasize what Angelo did emphasize in his final remarks, is that we don't deny that there certainly be some Medicare beneficiaries whose asthma might be better controlled under this model than they currently are. But just not convinced that the extent of that problem warrants an elaborate model of this complexity and this difficulty to evaluate its effect. And that's sort of the big picture problem that we face.
Yeah. And so Grace, this is Jeff. I just wanted to say that I think it's noteworthy that submitters are trying to get a specially based model for allergists and pulmonologists into the field. I also think that their approach on building out a model that really emphasizes team-based care is important. And I think that Angelo's summarized our overall assessment of the proposal, and I'll save the rest of my comments to address with the submitters. Thanks.
Okay. I received a message during this from the team that Dr. Kavita Patel lost video and is on the phone. So since I can't see a tent, I see nobody else that's right now asking questions. It looks like Paul has one. Jennifer, since I keep missing you, are you sure you don't have one? But let's make sure that Kavita also is able to communicate with if she's got one or not.
Thank you. I'll save my question for the presenters.
Okay. Paul, do you have a question for the PRT?
Yeah, just one of the issues highlighted was the complexity and well described. And I just wondered, in your communications with the submitter, and of course, the submitter, I'd be interested in their thoughts as well, but in your communications with the submitter, as you evaluated with them, was there any thoughts around, or is it better, did you obtain a better understanding of why it has to be so complex? I wasn't sure I clearly sorted that out by reading the material. Is there a way to simplify it, I guess?
Yeah, I think that's a great question, and would be interested to see how they respond. In our communications with them, I think their focus was that from their viewpoint, this seemed to be simpler than the present ICD-10 criteria that doctors have to document today, and so that was their rationale.
I'm not seeing any other questions. If you have some, flap your name. I don't see any. Okay. Well, hearing or seeing no others, then at this point we're going to introduce and move on to our actual presenters themselves. So we have three representatives from ACAAI joining us via WebEx. I would like all of you to introduce yourselves, and you have 10 minutes to make opening comments, and then we're going to open it up for questions for all of the PRT members to ask you for clarification of different things about your proposal. And I want to thank all of you for being here. So we have 3 individuals that are going to be presenters, Dr. James Tracy, Dr. James Sublett, and Bill Finnerfrock. So I'm going to just turn the mic over to you all and let you have the 10 minutes and tell who you are and tell us about your proposal.
Thank you, Chair and Co-Chairman Terrell. My name is Jim Tracy. I am with lots of feedback.
Yeah, if you could mute, just make sure that your others on the phone mute, so that you might be getting some feedback from other folks. It looks like Bill is lighting up, so he needs to mute. Thanks.
Thank you. Are we good?
Sounds good.
All right, thank you. I'm Jim Tracy. I am in private practice in Omaha, Nebraska. I'm an associate professor of pediatrics at the University of Nebraska and associate professor of internal medicine at Creighton University. And Dr. Jim Sublett's also on the call. Jim, could you introduce yourself, please?
I gotta unmute myself. I'm Dr. Jim Sublett. I'm been in practice 41 years, still see patients in our multi-site practice. I'm the past president of the American College of Allergy, Asthma Immunology. Was chief of allergy and immunology at the University of Louisville for 20 years before stepping down a couple of years ago. I've been long interested in asthma disease management. Some of the questions and discussions we're having today date back probably 30 years when that first emerged in the early 90s. We'll explain some of our complexity issues later as we go along today.
Bill Finnerfrock.
I'm Bill Finnerfrock. I work as a consultant to the College and the Advocacy Council on this project and a number of other issues, and have been involved in health policy for about 40 years. Thank you.
All right, thank you very much. On behalf of the American College of Allergy, Asthma Immunology, I thank you for the opportunity to discuss our patient-centered asthma care payment proposal. In my 40 years of practicing medicine, I've been amazed by the number of patients of all ages that coming to me believing that they have a disease and not yet really having that condition, often due to misdiagnosis. Or conversely, patients do not know that they have a condition or disease and opportunities are missed. This is true of the case with asthma. In about 20% of the patients labeled to asthma as having asthma do not actually have the diagnosis of asthma. And about the same number are not properly recognized as asthmatic. In either case, the outcome can be costly in terms of dollars and, of course, quality of life. Asthma is a condition that spans all age groups. It does not leave the elderly untouched, and the consequences of mistreatment or overtreatment can be considerable. The college's proposal is a novel APM and the first condition-based model designed to support the timely and accurate diagnosis of a chronic condition. This model is designed for collaboration between patients' primary care physicians and asthma care specialists, holding the asthma care team accountable for both outcomes and costs. And just as there are consequences with a particular course of treatment, such as cost or side effects, there's also significant consequences in not taking a necessary course of treatment. Accurate diagnosis is critical and a necessary step impacting both the outcome and the cost of this disease. This is the cornerstone of the PCACP. The model is designed to achieve multiple objectives. First, to ensure accurate diagnosis of asthma, also to promote local delivery of healthcare, to promote the mechanism by which specialists most able to care for the difficult to control asthma patients are involved in their care, improve overall outcomes, including decreases in premature death, ER visits, and hospitalizations, obviously reducing overall costs, and finally, to provide a value-driven, integrated asthma care team held accountable for meeting quality and cost measures with shared risk between the asthma specialist, primary care provider, and community-based services. The PRT in the review of January 20th, 2020 reported that the PACAC, quote, did not meet criteria in 6 of the 10 criteria specified by the Secretary. 3 were specified as, quote, high priorities, those being scope, quality and cost, payment methodology, and we'd like to address those briefly right now. The PRT notes that the limited scope and applicability of asthma in the Medicare population is about 7% in 2018. We do believe that although the numbers can vary between 3.5 and 4.4 million, that this number is not a trivial number. The PRT suggests that COPD should have been included in our model. Yes, COPD is common in this population, especially when considered with overlap syndrome combining asthma and COPD, thus making the diagnosis of asthma even more critical. We chose to focus on asthma and would be happy to discuss our reasoning during the Q&A. As an example, just ask one of my patients, Susan D. She is a 69-year-old retired U.S. Air Force colonel, both underdiagnosed and undertreated for well over 30 years. In her case, she was part of a large integrated healthcare system where the cost of care and accessibility of care were clearly not obstacles to care. It was not until being evaluated and managed by our small and attentive allergy practice that adequate diagnosis and treatment were achieved. Now at 69 years of age, she's actually able to be more active, sleeps through the night, and has nearly normal lung functions. In addition to a broad scope when authorizing the physician-focused payment model, Congress specifically instructed CMMI to test innovative models that are, quote, focused primarily on physician services furnished by physicians who are not primary care practitioners and to focus on practices of 15 or fewer professionals. Existing models such as ACOs are geared towards large integrated practices or healthcare systems that have a primary care focus. Many small practices around the country simply do not have the opportunity to participate in these programs. As Congress suggested, the PCACP model is focused on physician services that will be attracted to small single specialty medical practices, small multi-specialty groups that may not be a part of an ACO or other large healthcare system. Under quality and cost, one of PRT's objection was that our APM probably overstates the potential savings in the Medicare asthma population by assuming effects of improved asthma care would mirror utilization, spending, and savings reported for non-Medicare asthma population. However, there is no evidence that improved asthma care would be any less benefit for older individuals than for younger adults. In fact, the environmental scan produced by PTAC states that individuals aged 65 and older have the highest rate of asthma-related hospital stays and that the diagnosis of late-onset asthma among the elderly can be a challenging problem and is often delayed. This suggests potentially even greater cost savings in the Medicare population than with young adults. Another PRT stated weakness is that most of the studies cited in the proposal for younger patients that may not control for the fact that if a patient is enrolled in a management program, say due to an exacerbation event, that their expenditures may subsequently decline regardless of the treatment program that was implemented. We'd like to point out that most studies of healthcare interventions for all types of diseases have the same issue. There are no randomized controlled trials that support current CMS APMs, so it's unreasonable to criticize this proposal on that basis. The PRT also states that the program's quality measures could be improved by adding objective measures of quality. This model includes objective measures of quality, including spirometry, fractional exhaled nitric oxide, emergency room visits, and hospitalizations. We also note that subjective measures such as patient satisfaction and perception of improvement are appropriate outcome measures even in the MIPS program. Another weakness per the PRT is that the PCACP does not address payment and care management and how care and payment would be coordinated between the primary care providers and the specialists. The proposal explains that patients with well-controlled asthma would be managed by a primary care provider with support by the asthma specialist, and the difficult-to-control asthmatic patients would be managed by the asthma care team, consisting either of the specialists or the primary care providers with specialist support. As more care is moved from the specialist to the primary care provider, the PCP would receive a larger share of the bundled payment. However, we do not believe it's appropriate to be more specific, as divisions of care may differ based on individual practice and coordination arrangements. Using evidence-based guidelines, our model seeks to link stratified payment methodology with shared risk achieving cost savings through fewer or no, preferably ED visits, hospitalizations, fewer sick care visits, and more efficient use of medications, as well as to improve the quality of life for our patients. To our knowledge, the PCACP would be the first APM that explicitly requires the team-based approach to the management of a chronic condition. This shared team approach would also include levels of shared risk, making this approach especially appealing to Medicare or any other carrier that we believe both specialty primary care members and primary care members of the team. The PRT was critical of the PCACP's payment model as being overly complex because of the three components of care. For those of us that actually take care of these individuals, this is the reality. In point of fact, many patients do not present with a chief complaint of asthma. Often it is something else, such as coughing or wheezing or shortness of breath. And unfortunately, many who come in with the diagnosis really don't have asthma at all, but they have something else. Therefore, this appropriate diagnostic issue is really a challenge and the most challenging first step, and allows for cost savings by correct diagnosis. It's noteworthy that there are approximately 26 ICD-10 codes for asthma, but there's nearly 52 codes that may be presenting symptoms eventually leading to the correct diagnosis. We believe that the PCACP is the type of model, the exact type of model that Congress specifically wanted to see implemented when it enacted MACRA. For that reason, we were surprised when critiquing our model that the PRT suggested on more than one occasion that a properly managed ACO could perhaps achieve what we were proposing through this model. We do not believe that this should be the benchmark against which physician-focused models are to be judged. We believe that there are many weaknesses identified in the PRT are actually strengths in this model. Are there things that can be improved that would increase the likelihood that our proposal can add to the quality of life for asthma patients and save even more money to the system? Of course, but these improvements will, we believe, evolve organically as we learn the lessons of this model and make adjustments and refinements. But we cannot achieve this until we put this model into a field test to make adjustments where appropriate. Therefore, it's our hope that you will see a sufficient merit in this proposal to recommend that the PCACP to the Secretary for testing so that we can learn from it, make adjustments, refine the process. We certainly appreciate the opportunity to present our model today in this very challenging format. And of course, we welcome questions. Thank you.
Thank you. And you were right on time with 10 minutes. So I don't know if you practiced that or not, but that was awesome.
We don't practice.
And anyway, thank you, Dr. Tracy. At this point, I'm going to open up the questions for my colleagues who would like to ask them. And since we are in this challenging virtual format, I'll be calling on each of my colleagues who indicate or that they have a question or a comment. I'm getting some text here, as is Jeff, to help us say to make sure we get anybody, but because I know we've missed at least Jennifer once in the previous conversation, I'm just going to ask my colleagues that if I say any more, that you go ahead and get off mute and just interrupt if I miss you. And Dr. Tracy, we're going to actually direct all the questions to you, and then you can determine from your team who you think best ought to answer it. So with that, I'm going to look and see what we've got going on. I've just heard Jen is number one. So Dr. Weiler.
Thank you very much. Forgive me, but I have two questions. My first question is based on some of the comments from the PRT, so I would like to give you the opportunity to respond. The first is the concern around patient selection and this balance of garnering patient engagement versus what could be described as risk profiling that's favorable to the provider, but not ultimately to the patient. Obviously, this is an issue we see often with regards to APM, and that's patient selection and this balance of feasibility of the payment model to be successful, and then also adequately taking on risk. That's my first question. And then my second question is with regards to the concern around scope. Obviously, asthma, large problem in the United States, but when we're thinking about payment models that may be specific to Medicare beneficiaries. You address this, but I'm curious, why not expand it to other respiratory conditions, including COPD? And what I'm wondering is it because of this concern of taking on risk for a patient population where the outcomes may be more challenging versus that of an asthma population? Thank you.
Yeah, thank you. I'll go ahead and get started, then I'll pass it off to my colleagues. One of the disadvantages of being in this virtual setting, if we were actually in one of these committees, as I am with the FDA, I could just kick them under the table. So I can't do that today. So I'm going to start with that first question, and there's no doubt that cherry picking can be an issue. And it's certainly not, as you pointed out, limited to the APMs with asthma. One of our hopes were that we would have already tested this model before we came to you and kind of work out some of those details. And so, no, we recognize that that can happen. And how we control for that was actually a bit of a work in progress. Circling back to the COPD, we looked, before we chose asthma as the diagnosis that we were going to work on the APM, we looked at a number of disease states. And the problem is that as you add complexity, how you measure success also becomes more complex. So we wanted to take a disease, in this case asthma, that had fairly decent outcome data with it, and also some fairly stringent issues as far as stratifying between mild, moderate, and severe. Every time you throw in something else into the mix, you increase that complexity. One of the big deals that we faced is that there are a lot of conditions presenting as asthma for us as immunologists, including ABPA and certainly bronchiectasis. Those are fundamentally different. They behave differently, both in the clinical sense, but also in the practical sense. Dr. Sublett, would you like to kind of comment on the other points that she raised?
Yeah, I'd like to make a couple of comments about COPD and asthma. You know, we mentioned that and we recognize certainly that overlap is a problem. But the reverse of this is we often will see the Medicare age group come in as diagnosed as COPD, but they're actually not COPD, they're asthmatic. I think there's a tendency for primary care, urgent care, emergency rooms, et cetera, when they see an elderly patient or an older patient with a chronic lung problem like this, they immediately jump to COPD. I'll give you an example. I have a lady who had followed for a number of years, came in when she was 88 years old, had a long history of allergy, and her daughter brought her in because she had been diagnosed as having COPD. A non-smoker, she had been homebound for a number of years when I saw her at 88, and was on only albuterol bronchodilator nebulizations, PRN. We did an evaluation in the office. Her lung function in the office, first day I saw her, showed nearly a 40% improvement. Fast forward 6 months later, she was up to 70%. Fast forward 2 years later, 100%. She was not COPD, she was asthma. And we see countless patients like this. The contrary to that, and this lady, by the way, lived till she was 103 years old, 15 years after I initially saw her, with appropriate asthma management, allergy management, et cetera. Contrast to that, COPD, the time they hit the Medicare population, are usually pretty much fixed obstructive lung disease. And they generally, as we all know, are on a pretty much downward track. And one of the unfortunate things we see many times is that these people who have been mislabeled are just expected to go on that track, and we can change that. Other thing to comment on, the complexity of asthma is by nature of the disease, and that's why our plan is complex. The way we look at this, when we first see these patients, as Dr. Tracy mentioned during his presentation, they come in and we're often sorting out various parts of what's going on with them. About 20% wind up not being even asthmatic, and those will not stay in this APM. They will be moved back over outside the APM and hopefully treated for their underlying disease. What we call laryngeal tracheal reflux or vocal cord dysfunction are frequently misdiagnosed as having asthma. And they can present as fairly severe asthmatics because they're not recognized as having that underlying problem. So these patients will not remain in the APM. Once they're in the APM, if they're poorly controlled and we get them well controlled, we'll shift them over to the well controlled. And I think that, as Dr. Tracy mentioned, that is one of the key issues, is these are not, we expect a number of these patients to either, after the first phase, to move over and out of that asthma track entirely. And then the ones who do need aggressive management will be in the poorly controlled sector. We get them controlled, we often will be able to move them over. The other thing I wanted to mention was the issues, or that you asked, was we do have a number of these patients, and with the nature of allergy practices, we deal with some of the issues around indoor environments, smoking, et cetera, as part of our practice. So that was probably one reason we didn't emphasize that enough, maybe in our original proposal. And I'll turn this over to either Jim or Bill if they have any other comments.
Bill, it's up to you.
Thank you. I think that to go back a bit to the what in essence is the cherry picking issue, and I think Dr. Tracy referenced this, and it's a common problem with many of the models, but fundamentally it stems from the fact that the models don't appropriately take into account the comorbidities or the social determinants of health that impact the outcome of the patient and create the incentive on the part of providers to try and select patients that are most likely to have the most positive outcome. I think what's different here, and has been referenced, is at the front end of it, of trying to make sure that we have the appropriately diagnosed patient, and also that they get categorized into the proper area in terms of the model, and the incentive to move the patient from poorly managed to well managed, and adjust the payments to take that into account. And if they're not managing it, if that's going on, then they get penalized. So I think those are important parts. And as Dr. Tracy said, things that we see as strengths of the model, the PRT seem to think were weaknesses. But we think if you think of it differently, you'll agree with us that these are actually strengths.
All right. I'm going to move this along because we have two other questions that I see here, and I want to make sure that we've got time to answer everyone's you have time to answer everyone's questions. So the next one is Dr. Kavita Patel, I believe, is next up.
Mine's a simple one, and I just, well, one, I wanted to thank the submitters. As one of those internists who has gotten the diagnosis wrong myself and made the COPD diagnosis only to learn it was asthma, I do believe that there's some need for an element of this somewhere. I also struggled with some of the things pointed out by the PRT. Question I had, and I apologize because I had a video crash, so I missed about 5 minutes. This could be for the submitters, but anybody else in the PRT if they have the answer. Has there been aspects of this adopted by private payers in any form? We've been talking about the Medicare population. I could see because of the prevalence of asthma in commercial populations, has this been something that has been adopted in other places? And could you speak to how that adoption has gone as a payment model?
I'll speak to that, Dr. Bell. So, and then the other committee members also. The short answer is not that we're aware of. When we crafted this, we actually started developing this with that in mind, that this wouldn't be just a Medicare model, that this could be extrapolated at a much broader scale. But when we look back at it, we can't find anything that blends in the shared responsibility piece along with risk stratification, kind of circling back to that cherry picker question. Well, so if we risk stratify our situation and we have individuals who are going to be sicker, okay, they're not going to be, that will be accounted for in your payment model. So there's less incentive to cherry pick with this model because you're stratifying it for the sicker patients. To be frank, we want to take care of the sick patients. We think we can do a good job, but we also feel like there's a place for stratification so that you don't cherry pick. Thank you. Anybody else can chime in here?
I'm going to move us along since I think you answered her question. So I think Dr. Jeff Bailett is next with a question.
Thanks, Grace. Again, want to compliment the proposal submitters for coming up with a specialty-focused physician model, and again, compliment the team-based approach, which I think is one of the cornerstones of how the specialty and primary care community can address better serving patients. My question, I'm trying to understand the scope. You guys have already clearly articulated why you didn't include COPD. And when I looked at the senior population, which this model is targeted for, about 61, almost 62% of those folks have COPD and asthma. And then you also excluded lung cancer, and that's another 3.5%. So just on the math, about 65% of the population of Medicare folks with a diagnosis of asthma also have exclusion criteria. In addition to that, there are folks who get eliminated if they are smokers and they don't cease to smoke. And just again, in my back of the napkin, and you guys can confirm this, but from what I could ascertain, about 18 to 20%, let's say, of seniors who have asthma are smokers. And of those smokers with asthma, it looks like the literature looks like about 20% of those actually quit within the first, or quit and have quit by 1 year. So I'm just trying to understand what is the universe of patients at the end of the day that this model would apply to. Thank you.
Dr. Sublett, you want to take that?
Well, I've already mentioned the high rate of misdiagnosis. I expect that some of that 61% of COPDers are actually asthmatic. My work over the years with disease management, and I worked with a large managed care company a few years back, and they were working on COPD, and I met with the group and I brought up the fact of overlap, and actually that some of them were asthmatic, and there was this deer in the headlights look that it's not even considered. And I think that the numbers are probably, my feeling is they're not accurate. I think as we get into this, we'll find a lot more asthma that are not COPDers than people realize. As I mentioned already, a lot of that diagnosis probably comes from primary care who don't have facilities in their practices where they can do spirometry. The use of fractionated nitrous oxides really helped in determining whether patients, including those who are smokers, and may actually be asthmatic. I think the other thing, we're seeing an aging population, and we know that the numbers are actually probably pretty. I've looked at the recent CDC data, and you can just about roughly say that about 10% of the general population are asthmatic, pretty much across the board. The numbers fluctuate up and down a little bit year to year, but if you look at the overall numbers. So as we expect the Medicare population to increase over the next few years, we're going to see more and more likely patients with asthmatic. The issue about addressing smoking cessation, that's been built into the practice of allergists. That's what we do every day when we look at patients. These are triggers, and I've actually spent most of my career working on things like small particulates, diesel particulates, pollution, et cetera, that affect asthma. That's something we'll counsel patients on. We're not going to give up on them. I think the issue in general was non-adherence, and that's an important factor in any kind of chronic disease management. Whether you keep beating your head against the wall of people that are non-adherent. We'd expect that number to be fairly low in this kind of population management approach. Bill, you may have some additional information on the population we expect to see.
Not have any great amount. I mean, I think your point was the one I would have made, which is that, we're going to see a dramatic increase in the number of Medicare beneficiaries, and there's no indication that asthma is going to be any less prevalent. And so as those numbers go up, I think it's going to be an even more significant population, and the opportunity for savings moving forward, not just looking at what we see today and looking in the past, but projecting forward, that this is something where there's a real opportunity to achieve a different way of providing care, provide savings to the Medicare patient, and improve the quality of life and the quality of care to that population.
And I'll just add too that a lot of these issues such as smoking, we talked about this briefly, compliance would be we believe would be better in the integrated plan that we're suggesting.
I have some questions, but I want to make sure that Charles and Paul and Angelo don't have any. I didn't get any message that you did. Angelo, do you have any questions? Somebody's telling me I'm supposed to ask you that. And we're not hearing you. If you may be on mute.
Hello?
Hi. We can hear you now.
Can you hear me?
Yes.
Okay. What I'd like the team to comment on is how they feel this alternative payment model would solve what sounds like an inability of the present fee-for-service model to allow a doctor to make an accurate diagnosis. And what about the fee-for-service model impedes that accurate diagnosis?
Well, there's several things. First of all, and I should tell you this was kind of pre-COVID a little bit here, but we when we looked at this, a lot of the things that we sort of feel should be a critical element, which would include, by the way, telemedicine. Those really are not, again, pre-COVID, were not particularly compensated well for by Medicare. And a lot of the other things that we believe are part of the team, really, although some of them are technically included, the practical reality is that the reimbursement was pretty tough. And plus, there was a fair amount of fragmented care. And we hope that this will kind of get to that point. But in any time when you're having a fee for service, you're incentivizing to see the patient perhaps even more than you were before, and doing things that you may not necessarily need to do or want to do. Dr. Sublett, you want to comment on that at all?
Yeah, I think looking at just from our standpoint of patients, we see the fee for service discourages, especially primary care, from having the time to spend with these patients for counseling. We're talking about smoking cessation, but one of the big factors is avoidance of triggers and that sort of thing that we can counsel. Medication adherence. Some allergists actually have the ability to do detailed environmental assessments. And now that we have telehealth available, that would be one aspect we could incorporate. We've talked about a lot of these things theoretically, but I think, as Jim just mentioned, telehealth the populations that we deal with, there's a much higher rate of African Americans who wind up in the hospital, who die from this disease, about 4 times the rate of the general population. Those kind of patients with some of the other additional benefits of counseling and so forth we bring to the table in our practices could benefit. And working with primary care, the primary care is interested in this disease, but I think their time they can spend with the patients so limited that, especially in the difficult to control patients, we're able to bring that to the table. And working as a team results in much better service than the standard fee-for-service that we see now.
Thank you.
Thank you.
Any questions from Paul or Charles? You don't have to have any if you don't want to.
I don't have any questions. Thank you, Grace.
Okay.
No questions from me. Thank you.
All right. I have just a very quick question, and that's related to the fact that this is very specific to allergy and immunology and primary care, but at least in my experience as an internist, asthma involves other specialists quite often as well, such as ENT gets involved sometimes as it relates to hoarseness or vocal cord dysfunction. Certainly the pulmonologists take care of a lot of asthma in my community, and the gastroenterologists certainly do, as a result of the fact that 60 to 80% do have GERD, at least in certain statistics, as well as things like eosinophilic esophagitis. So I guess my question is, by limiting it to one specialty, which is really intentional in that you're looking for a specialty primary care team basis, my question is, what is the role for the other rest of the team members that potentially may need to be involved in the care, or in certain communities would be involved in the care of patients with asthma?
You know, I am so glad you asked that question. So when we started this model, and in the initial comments when they were kind of going through the model, they talked about allergists and immunologists. So our starting point when we started this thing was that it wasn't going to be, even at the specialty level, just allergists and immunologists. It's asthma care specialists. Somehow pulmonologists got left off the slide, but I want to make it really clear that we include pulmonary in this. Basically, in order to get CMS to buy off on this, which would be our goal, obviously, this has to be attractive to all the stakeholders. So when we looked at this, we looked at it, so what would be attractive for allergists and immunologists? Well, that's what we are, so we knew that was pretty straightforward. Definitely pulmonologists, for sure, depending on where you are in the country, but also to family doctors, pediatricians, and internists. So that's the big picture. So let's circle back to the other guys. So in GI is definitely an issue. That's something that's going to evolve with time. Clearly, that's relevant. There's no doubt that ENT, and it's not just with vocal cord dysfunction, sinus disease is probably even a bigger player and very expensive. We actually consider looking at sinus disease as one of our APMs. The complexity is colossal. And as challenging as asthma is, you start blending in a surgical and a non-surgical specialty with those two stakeholders, and you got conflict on you. So we recognize that they're there. How that actually evolves in the model, should it be implemented, is definitely a work in progress. Thank you.
Okay. Well, thanks. Thank you. And if there are no, I'm going to assume there's no other questions from our commissioners.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.